il Covid, se non il post-Covid, quello sì.
Okay. So now, before it says too much, otherwise I'll get lost. He says that they have treated about 100 patients so far, and the results of these treatments have been published so far on Facebook.
Let me read it today. And
they are now waiting for the authorizations to make a more official publishment of what they have done. They hope to receive it as soon as possible, but everything they have obtained is open to everybody. Everybody can consult it. It's not something they are keeping just for themselves.
Bene. E il protocollo l'abbiamo dato all'Istituto Superiore di Sanità.
We have given our protocol to the Italian official Institute for Health,
che è del
the
Ministero della
governmental
Sanità,
belongs to the Ministry of Health.
E ci ha dato il via a poterlo utilizzare previo il consenso del comitato etico di ogni ospedale.
So the Ministry of Health, so to say, has given us their okay to use our protocol, but it has to be approved by each and every hospital that decides to use it.
I nostri risultati, se non li avete, ve li mandiamo e, come vi dicevo, sono risultati che arrivano e sono conformati fra tutti e 15 gli ospedali.
If you don't already have the results that we have obtained, we are very happy to deliver them to you, to give them to you. And they are not the results that we are writing, but they are the results that have been elaborated by all the 15 hospitals that have used our protocol.
Ogni ospedale ha utilizzato il proprio protocollo farmaceutico.
Each of these hospitals has used their own drug protocol.
E in più una parte hanno utilizzato solo il protocollo farmaceutico e una parte hanno utilizzato il protocollo farmaceutico più l'ossigeno Ozone.
And when treating the patients, some of the patients have been treated only with the drugs, while others have been treated both with drugs and ozone therapy.
Non so se il professor Valdenassi voglia dire completare questa.
Perhaps Professor Valdenassi would like to complete.
Non lo vedo più.
Sì, sono. Thank you for your kind invitation. My name is Luigi Valdenassi. I am a teacher of University of Pavia, and from 1997 president of Italian Society of Ozone Therapy. We have presented clinical protocols to ISS, Istituto Superiore di Sanità in Italy, and in 15 hospitals there was a therapy with ozone and standard therapy. Standard therapy is chloroquine, heparin, and ozone. And then other group only standard therapy. The results are very good for the marker of inflammation, leukocyte, and many other markers. And if you want, we give you, translate you the results. Thank you.
Thank you, Doc. So, Dr. Frazzini and Dr. Valdenassi, you're doing autohemotherapy, right? Is that what you're doing?
Autohemotherapy.
Okay.
Yeah.
Okay, just wanted to clarify that. Okay. Dr. Simone Childs-Walker.
Hello, everyone. I'm Simone Childs-Walker. It's an honor to be on the call. I'm in Minneapolis, Minnesota. I'm a resident physician. I have interest, though at this point in my career, not so much experience with ozone therapy, and have been part of helping to, at least in a supportive way, peripheral way, bringing this group together. I'm also going to report back to a group of practitioners in Minnesota who are who run Ozone through their clinics. We don't have hospital infrastructure here right now, but potentially could move that way in the future, and happy to contribute in any way I can. Thank you.
Thank you. Dr. Silvia Menendez.
Oh, well, good morning. It's a pleasure for me to be sharing all our experience with all of you. I am, I introduced ozone therapy in Cuba in 1986, and we created there the Ozone Research Center, where we were the head of all ozone applications in all Cuba. We have made a lot of preclinical trials and also clinical trials. And furthermore, we have teach and we have offered national and international courses in order that persons can be familiar with the use of ozone therapy. Now I am retired. I am living in the United States since 2016 and continue teaching ozone therapy and make training, a consultant of ozone therapy. And well, I am here to offer all my help in order to justify the use of ozone biochemistry, to use the use of ozone in this COVID.
Thank you, Doctor. Dr. Alex Frantzis.
Okay. Hi, my name's Alex. I've had a lifetime background in oxidative therapies, and since January, I've been trying to do whatever I can to help move that forward for COVID in the United States. And I'm really amazed that this group's come together, and I've periodically corresponded with some of you. And one thing that I wanted to mention, now is a good time as any, is I think that we should be very careful on making any type of public announcement about this trial until it's FDA approved and it's started, because I feel that that could otherwise be a big roadblock to it getting approved.
Thank you, Alex. Dr. Howard Robbins.
Hello, everybody. Can you hear me?
Yes. Yes.
Oh, good. So I've been doing ozone therapy, intravenous ozone therapies predominantly since 1990. I did 45,000 major autohemotherapies approximately plus between 1990 and 95. I've done over 305,000 Robbins method, which I call it now, direct intravenous ozone therapies from 1995 to the present. I've done about 500 hyperbaric high dose ozone therapies using the drrowen method with Lahadny multipass. I've done probably only about 50 or 60 ultraviolet blood irradiations now, so I don't have a deep experience there. Rowan and I went to Ebola land in Sierra Leone, and we published on that. I'm co-author there. We also published, I think, the first paper on COVID here. I've treated four or five now COVID patients with direct IV very successfully, along with a little bit of Hocket sauna, which has been worked very well in combination, very successfully with the COVID patients. I'm published on complex regional pain syndrome with Robert, that I've been able to get rid of that. I've also published myself on mold and mixed mold mycotoxicosis using ozone therapy. And Rowan and I have some more publications on our way coming out very shortly, including a very expensive study that we did on the safety of Robbins' method of direct IV. And as Rowan and I have lectured all over the place, and I've trained several, I guess, dozens of doctors now who use my method around the world. And I thank you very much for letting me be here. I do believe that if you filled a water gun with ozonated water and shot it at a COVID patient, it would probably get rid of the virus. I'm in favor of any method of ozone therapy on any clinical trial that we can get going in this country, and I would do anything I can to help anybody in any trial go and get going, including if we need money for it, ponying up some of that as well. Thank you very much for listening to me.
Thank you, Doctor. Dr. Paolo Tordiglioni.
Yeah.
Go ahead,
Yes,
Doctor.
hello. I'm so sorry for being late.
Hello.
Just got a meeting. And thank you for having me in for the meeting. I'm actually talking from Rome, and I've taken care of a protocol with Ozone with the University of Rome La Sapienza, and has been approved by an ethical committee, and we're treating patients with COVID-19 positive swab. And for now, I mean, we've collected up to 26 cases, but the cases are actually done. I mean, for here in Rome has been, hello? Yeah, it's the pandemic or the infection in Rome is gone down. So we don't have any new cases. Anything I can give, anything I can communicate or share, I'll be happy to.
Thank you, Doctor. Dr. Mark Hyman.
Yeah, I'm Dr. Mark Hyman. I'm the head of strategy and innovation at Cleveland Clinic Center for Functional Medicine. I'm relatively new to Ozone the last 3 years and learned from Howard Robbins and Robert Rowan, and found it very effective for a whole range of conditions, and just trying to support any way I can to get a trial going around COVID.
Thank you, Doctor. I have Dr. Deborah Viglioni.
Hey, I'm in the car. Sorry.
No problem.
Can you hear me okay?
Absolutely, we can, yeah.
Hey, I'm an internal medicine integrated physician in Gulf Breeze, Florida, and I've been doing this for about 14 years, primarily for viral and cancer, and I've used the major autohemotherapy as well as ozonated therapy IV in the saline, and I've pretty much stopped doing the major autohemotherapy in favor of the ozonated saline because I feel like it's similar to doing the direct IV. And I've had good results. We really didn't have as many COVID patients as I'd hoped to be able to treat, but everyone I did treat, got turned the corner within 24, 48 hours. So it was really good, and I'm excited to be part of this group because I really want to. I kind of been hiding from the FDA, but I'm ready to get out and do something.
This is the time to come out. The time to come out.
Yeah,
Doctor.
it's time to get out there.
I think COVID is going to give us that chance. Now, I can only see what you put on your identification. I see I pipe de Alberto, so I'm not sure. You wanna go ahead? Yeah. Go.
It's me. Hi everyone, it's a pleasure to be here with you all today. I'm Alberto Hernandez, one of the anesthesiologists here in Ibiza. I'm the pioneer in Spain using ozone therapy in COVID. As Mark Vives told before, we're trying to publish our large study, which has been difficult in a traditional journals, so it's been rejected by JAMA and CHEST. So we're still trying to do in a conventional journal to get more publicity. We already published our short cases in American Journal Case Report, which is has been accepted already. And we're struggling with the agency here, the equivalent of the FDA, to get approval for a clinical trial, multi-center clinical trial. We're filling around 200 pages every week to explain to them that the ozone is not possible to keep in everywhere in the hospital, and not possible to measure the concentration in blood, and blah, blah, blah. So hopefully we can get the approval when we don't have any COVID patient in Spain. So we'll see what happens in the future. But it's a pleasure to help here with everything you need.
Don't worry about that, because we have plenty of COVID patients in the United States, so we're take over for you, unfortunately. Dr. Lila Marcus.
Hello, I'm not a physician. I am an administrative assistant to Dr. Thomas Schneider, We started a clinic in Ponte Vedra, Florida, the Healing Breath Institute. We had to put that on hold because we couldn't get the support or financial backing or anyone to support treating our patients with ozone. So we are looking to collaborate with any and all that are looking for a way to move forward with helping to get rid of this virus and other things with ozone. We also do many other alternative healing things, and we're trying to put forth a business plan and collaborate with whomever is willing to do that. But I am going to continue to be the administrative assistant to Dr. Thomas Schneider and hope that we can work and support any of you in this very important time and venture with ozone.
Thank you. Now I see there's an iPad that says 18505. Whoever that person is, if you want to introduce yourself. I'm not sure. Maybe they don't know that's their number. GSICAE. If you want to introduce yourself, or also Carl.
Yes, my name, can you hear me?
Yeah, go ahead.
Hi, Jack. Thank you for putting this together. My name is Dr. Jim Thorpe. I come from probably a strange background for you all, but I am double boarded physician in obstetrics and gynecology and in maternal fetal medicine. I've been extensively published in my career, primarily related to oxygenation, respiration of the mother, placenta, and fetal unit. I've published extensively on treating the fetus in utero. So I'm employed by the largest Catholic healthcare system in the United States through SSM Health out of St. Louis, but I work full-time in my home office doing telemedicine for them in Gulf Breeze, Florida. Dr. Viglione and I, we're both military background, and we just completed a trial using ozonated saline, looking at the effects in a hypoxia model. And it's accepted for publication, and we're moving on to phase 2 with ozone. My interest, I have a key my background is chemistry, physics, biochemistry, in addition to medical school. I've been using ozone I've been studying ozone for a long time. I've been using it for 2 years, and I'm extremely interested in supporting this group. I've been together with this group and with Sheila in Texas and Dr. Hernandez in Spain, and been talking to them for a long time. And I have my own biases, but I will put my biases down with regard to the method of ozone administration to support everyone in this group in any way that I can. We do, I have a unique connection to the US military, and multiple of the co-authors on this paper that was just accepted are kind of surrogates, if you will, of the Surgeon General. So we're working through that avenue, but I'm not a huge, I'm a very huge proponent of studying ozone more in the United States in a scientifically valid manner, a randomized controlled trial. And I have designed a randomized controlled trial that I think would work. I'm happy to accommodate each of you and anything we can put together on a United States effort, international effort to study this in any method of delivery which we can agree upon. I put agreement and unanimity over individual biases. Thank you.
Thank you, Doctor. Did I miss anyone? Please, if I did, please go ahead and introduce yourself.
I'm Sheila Hemphill with Texas Right to Know in Texas. And it's a pleasure to be here. when my April 2nd press release got published, some comments was, we can't believe they published it because ozone's been evidently such an understated word. And as we just talked about earlier, you can't put the word treatment and COVID in the same sentence, Jack. That's probably why your email, or why your web video may have gotten taken down. It's a pleasure to be here. I am been actively keeping up to date the Texas Senate and House Health Committees Chair and Vice Chair, as well as the Texas Medical Board immediately opens my emails. So they've been aware since March 10th, when I was trying to tell them that ozone is effective of treating COVID, and also delivered it to the head of the emergency management. Has anything happened from all those communications? No. That's because legislators legislate, agencies make rules, and nobody does anything, unfortunately, until we get this FDA. So Jack, thank you, and Marcus and Larkin Hospital for getting this group together and getting it moving. So I would love to hear what the protocol is actually looking like from Larkin. And I don't know if you can pull it up to look at it, or what's the next on the agenda. So thank you.
Yeah, actually, Dr. Richard's going to go into that. I just want to make, I think one more person to introduce. Oh, by the way, so the video didn't say anything about treatment. It just said this is a demonstration of how to administer ozone. So just so you're clear. So I'm not sure why it was taken down by YouTube, but did we miss anyone else from introducing? I know the people from. I'm deliberately not introducing our team from Larkin because it's a lot of people. We have a number of medical graduates that are part of this. Sanjay Mahat and Adarsh Shetty and Walter Raymond, Ewan Ubomwan. But did I miss anyone, any other physician that's not part of the Larkin team? Dr. Marcos Sanchez-Gonzalez, do you want to quickly introduce yourself before we go to Dr. Richter and we can go over the protocol?
Sure. Dr. Marcos Sanchez-Gonzalez. I'm the current Vice President for Research and Academic Affairs at Larkin Community Hospital. Physician scientist. My background is in cardiovascular physiology. I have several appointments as a professor for clinical research, and in any kind of research endeavor, statistics that I can be of support, I'm here. I'm very open to collaboration and glad to be here.
Thank you. Dr. Richard, let's start going over what Dr. Rowan has something to say before you take. Go ahead, Dr. Rowan.
Thank you very much. I just wanted to let the group know that there is an article that's been submitted to publication. I'm third author on it. It's the work of David Brownstein in the Midwest. 106 patients with COVID, 33 tests were positive. They just couldn't get all the testing done because there weren't enough tests. 26 were positive. He used a combination of nutraceuticals, which I would like to see our group do if everyone's interested, and also intramuscular ozone, IM ozone, not IV, not DIV, intramuscular ozone gas. Of the 106 cases, all of them recovered in only 2 hospitalizations. That's in publication now.
In what journal?
I don't know yet. He submitted it, and I can't tell you. I do not know if it's PubMed indexed. It's almost impossible to get something in. We were rejected on the Ebola article, believe it or not, and his reward for getting 106 patients better was to be shut down by the Federal Trade Commission for even mentioning that he was getting the patients better on his website.
What state was that, Robert?
Michigan.
Okay, that's good to know. Dr. Richter, are you, I think I lost you.
Yes.
Oh, you're here. Okay, go ahead, Doc.
Yes, well, what we are doing at Larkin's is we're gonna start doing using what will be the MAH, the Mayor Autohemotherapy protocol that I learned with Dr. Schallenberger 10 years ago, and I've been using, which is basically using 200 ml of blood, mixing with ozone in an equal volume at the concentration of 40 gammas. In some cases, we're gonna use probably 30 gammas or 20 gammas after my assessment, and if the patient has an oxidative stress high, for example, if it's a heavy smoker or long-term diabetic or has been taking maybe chloroquine, so all these other oxidative therapies can decrease, of course, make it more susceptible to ozone. So we are not just using 40 for everyone. I'm trying to kind of customize, okay, which one is gonna start with a lower dose, but let's put it, say 40 as an average to start. And we plan to do once a day, at least for 5 to 7 treatments. Ideally will be that daily treatments. We're gonna reassess and trying to put together a dyspnea scale, evaluation scale, which is more sensitive, has 12 points. It's just an assessment of the activities of daily living, like brushing your teeth, combing your hair, speaking full sentences, and have a level of each one. So that way, in 2 days or 1 day, or every 2-3 days, we can see actually if there is an improvement. Using the World Health Organization scale to see improvement of 2 points could take maybe 2 weeks or maybe even more. So that's why I'm trying to, additionally to that, use this scale that is still for review. I'm just, I just kind of put it together this weekend. And definitely I will happy to share with all the groups and have your opinion of that. And that's what we're trying to put on the study, maybe additional to what I read from Italy, from China, from Spain, that we are all definitely using some of the guidelines they already using. And we're just finishing to the IND protocol. Probably by today or tomorrow, we can share the kind of the final version of that. Alexander Frantzis is helping with that editing, but I'm receiving recommendation from the different doctors, so I'm trying to make small changes. So and that's still open, so you can all submit your comments on that. Okay.
So I just want to make sure that if you're in this call and if you're not on the email group, please input your email in the chat so that I can include you. We obviously would like to send everybody the protocol and have you critique it, because obviously this is very important. This is the first, hopefully this will be the only, well, hopefully it won't be the only in the future, but at least it will be the first one approved here locally in the United States. And so that's all we want to make sure that we look at every single, we examine it very carefully, and we're sure that everything we're putting in there makes sense. And if you have any suggestions, obviously, we would love to hear them and adopt them. Dr. Hyman, the people that you wanted to connect to in Italy, are they in this phone call?
Yes, Paolo's on the call, I think.
Okay.
Right? And Paolo is the one who I think was doing the trial in Rome, who I think had a lot of experience, and I think is, far down the road, and thought it may be helpful to get his opinion about how we design this.
Excellent. Excellent.
Absolutely. If I can say, I mean, our protocol is in clinicaltrial.gov, so you can get hold of the actual protocol from there. And if you want anything, I mean, any question I can answer, I'll be happy and very glad to reply or to.
Was you the one using hydrochloroquine and the erythromycin and the probiotic? Was that your trial?
Yes.
Wonderful.
Yes.
of all these trials that are going on, it's all pretty consistent as to how much blood and how much ozone, and concentrations range anywhere from 20 or 30 down, the lowest I've seen from Japan, all the way up to 60 and even higher, some reports. So there's a range that kind of varies. The protocols also vary of how many times a day. I know Alberto, I think y'all were using twice a day for non-complex.
Yeah, we do twice a day in the no critical patient, and we did 4 times per day in critical patients, in intensive care patients.
And then the Italians were doing once a day, and I'm not sure what their concentrations were, Dr. Franzini, of the concentrations of ozone and how much blood y'all were pulling. Luigi?
Yeah, if I have to reply on our side,
okay,
on our side, we're doing it twice a day, and we're giving 40 micrograms of ozone over a week of treatment. So that comes to 14 times a week, and that's it. The actual thing that I would say that we did not do, and I think it would be a very good idea, is to dose the capacity of the patient to have an antioxidant reaction, sort of understand where the patient stands in terms of antioxidant capacity. That could be quite interesting, because it makes it interesting to understand also how ozone interacts, because it is very different depending according patient to patient. So that would be something I would put in.
I know some studies were also having vitamin C done afterwards. I believe, Alberto, y'all were using vitamin C after the ozone. Then I talked to my statisticians, Dr. Thorpe down there, who's 18505, who really want to get into how the studies are done to get the purest data. This is like our first rodeo here of getting ozone introduced to the United States. Dr. Hyman, do you have some recommendations on how far we can try to get? I know some studies have talked about having the baseline be some of the biologicals that Robert was talking about, nutraceuticals, that everybody gets the nutraceuticals, and the experiment would be the ozone. So, but then my statisticians go, oh, you can't do that because it will, anyway, your input.
I think we all know that a comprehensive supportive approach, including diet, nutraceuticals, are a great idea. IV vitamin C, but the problem is that it's going to dilute the results. And I think if we can establish just simply using ozone that it's effective, then other things will be layered on. But I think if we're trying to establish ozone for the first time in the US, pure ozone, even though that might not be the best therapeutic approach.
So, did
100% agree with Mark on that.
you agree?
Yeah.
Okay. Yeah. How about some thumbs up on that? That it's ozone only. Okay.
It's Jim Thorpe here.
We've got a problem here. I think we've got a problem here because, as I understand it, this is an adjunctive therapy that's to be overlaid on top of what the hospital is already doing. I think when you evaluate the protocol, make sure to take a look at the sheet that shows the current set of protocols for COVID patients right now. And if that's going to change, that's going to require some major rethinking of the entire process here. So you got to really look at two different things: the ozone protocol per se and the hospital protocol onto which it's going to get layered.
I believe this is Jim Thorpe. Dr. Hyman, I agree with your statements. The problem is that, in my opinion, in getting trials together, there's no hospital that's going to put everything else aside just to do ozone only. I agree with you, Sheila and Dr. Hyman, in that sense statistically, but that's why we do randomized controlled prospective trials. And according to my analysis, with a power in excess of 80, we can demonstrate a 50% reduction in progression of the disease with 1,000 patients. And that it doesn't matter really what the other therapies are. If there's a substantial effect size that you all are reporting in Cuba and in Spain and in Italy, then that will still come out. So that's my opinion there. Dr. Rowan, Sheila, and I'm sorry I missed the other doctor's name. Tell me exactly how many direct ozone gas infusions intravenously that you have done and what the risk is.
What were you asking? I'm sorry.
I was asking Dr. Robert Rowan and the other doctor.
Robbins and Rowan.
The other care providers.
Well, okay, I can answer that. Approximately a little over 305,000 direct IVs in New York State, which says if I kill you with a pharmaceutical, they don't care, but if I hurt one person with ozone, I'm out of business. And my board knows what I do, and we've only, by modulating the therapy the way I've learned to modulate it for each patient if necessary, we've had no harmful adverse effects other than severe herxing once in a while. But here's the thing.
Dr. Rowan reported 4 deaths.
But there's never been a death reported on DIV in the literature, but there are several deaths reported in the literature and to the FDA with MAH, along with some myocardial infarctions, and that's in the literature right now. But that's neither here nor there, because I'm way in favor of using MAH for this study. I think it's a perfectly fine, it's a comfortable method for the doctors who understand putting something in blood and then putting blood back into the body. I think it's I think any form of ozone therapy is going to work on this. As it's already been proven here.
I would argue, and again, I'm willing to lay down all my biases, but the MAH is too complex in the United States of America with all the personal protective equipment and all the ICU care providers and the physicians. My preference would be direct IV ozone or ozonated saline, which Dr. Viglione and I and my collaborators have had incredible results with. I am also concerned that with the inflammatory mediators and the platelet release reaction when the blood is outside of the body and it's getting massive doses of ozone, I'm concerned about the inflammatory mediator products causing these strokes, heart attacks, and deaths that have been reported in the literature.
May I say something?
Comment, please.
Yeah, actually, go ahead, Dr. Menendez, and then we'll follow Dr. Rowan.
If we are lucky that they accept our protocol, we have to use the ozone application the most studied, and we don't have any published article about DIV, about ozonated oil, about ozonated saline solution in peer-reviewed journals. Then the only thing that we have in hand that can convince the medical community is the major autohemotherapy. We have made toxicological tests, genotoxic tests using major autohemotherapy. There's a lot of papers published using that. We have been working in major autohemotherapy for a long period of time. It has been a lot of articles that justify the use of these methods, and it has a control, a modulation of the anti-inflammatory agent. Then we have, if we want to be accepted, we have to use the way that is more studied. Then I don't saying that Dr. Rowan has obtained good results with direct IV, But now we have to use these things that can convince. We will have time for proof and other ways, because if not, they will not approve. We don't have any article about the direct IV. Then they will say, well, how can you prove that? And the other thing is that it's very difficult that FDA can approve something that is new with only using ozone in COVID. I think you have to use it ozone as an adjuvant. The conventional treatment plus ozone compared with conventional treatment. We have to do it, the things, thinking that it's possible to be accepted. And this is the way. We cannot, just now that they don't know nothing about ozone, you cannot put a group only with ozone. We use it as adjuvant, as we have used it in Spain, in Italy, in China. Even yesterday, I was in a chat with Peru, and they are using ozone also with very good results using autohemotherapy. Even in the Peruvian doctors that, for example, have obtained some troubles with doing the autohemotherapy because sometimes the patients will coagulate the blood. Well, they use first rectal insufflation 2-3 times, and then it will be very easy to continue with autohemotherapy. But rectal and autohemotherapy are very well studied with toxicological tests completely. Then if FDA will ask us, we will have something to demonstrate that it's possible to do that, only to give us a chance, but not use, just now, not use something that is not being published.
Yeah, I'm fully agree with Silvia. We are struggling for 2 months now with the same problem here with the same FDA agency in Spain. And this is why we choose this route, because conventional, there are a lot of papers. It's more common for doctors. The management is nothing to be scared because it's a simple method to administer ozone. So, and even we are still answering question about the standard protocol. So it's crazy if you try to get approval in a hospital removing the standard treatment. So I fully agree with Silvia. You have to the randomized standard hospital, whatever they use, because every hospital uses different medication, and then plus ozone. And as I mentioned before, the recovery of the patient is very fast. So I think it's even with some sesgos, but you have a lot of information to publish the benefit of therapy in the group. So I fully agree with Silvia. Don't try to do different experiments. Down everything.
Look, I've done more DIV than anybody else in the world, and I think MAH is the right way to go for this. I totally agree with Silvia, and I totally agree with Alberto. DIV is not the way to go this time. It's best to go MAH because we're going to get great results anyway, and they'll be more happy about it. There are papers published on DIV, Silvia, but there are many, many, many more published with MAH. And you're right, that's what the FDA will look at, and we can show them all the literature on it. MAH is the way to go, but in glass collection bottles, I hope, not in plastic, just for safety's sake.
Fully agree.
My comment on this is similar to Howard. I think that we will have less obstruction with MAH over any other method. We chose the DIV method for Ebola mainly because of possible contamination and spread, and Ebola is much, much more dangerous than COVID. On the other hand, you're going to have patients who don't have good veins, and that's why I mentioned earlier that a paper is in publication now. It's an observational study. It's not what this group is trying to do here. on using IM ozone. And that's a lot easier to do than ozonated saline. And if for the patient who doesn't have veins, you might be able to do a sidearm of IM plus or minus rectal ozone. I don't think anybody would argue with the problems arising from that. In Africa, most people don't know this. After I left, the project was shut down by the government, probably because of pharma. But a doctor whose life was saved, he stuck himself with a contaminated needle, secretly brought in ozonated water and bags of ozone gas into the patients at the Freetown Ebola clinic, and the death rate mysteriously, and I'm putting that in quotes, mysteriously dropped from 60% to 25%, and no one knew why, but we knew because he was secretly bringing in ozone for water and rectal.
Rob, when you're saying IM ozone, are you talking about minor autohemotherapy there?
Raw gas.
Just straight gas.
Just straight gas. I happen to believe, and this is what led me to go to Sierra Leone, and this is why I wrote, Howard and I wrote the report on COVID. These viruses are very vulnerable, in my opinion. They need reduced cysteine and tryptophan in their protein coats to enter the cell. And cysteine, I thought, was the most vulnerable amino acid. It appears that tryptophan might be as or more vulnerable even than cysteine because it's got an indole group with lots of electrons that are easy to be captured by ozone. And my own feeling is just moving the redox status of the blood into an oxidative condition, just in almost any form of ozone. And I learned this from Silvia. To me, she's my great teacher. Rectal ozone, no matter how you give it, ozone water, I think is going to tip the redox state towards oxidation, and I think you'll inactivate a lot of the virus particles and get an immune response no matter how you do it. I'm on board with whatever you guys decide to do, but I think for the patients who don't have IVs, we do have alternatives that don't have to include DIV if that's not the way we want to go. The interesting thing about what Brownstein's group did is they gave IM ozone gas, and I'm just sharing this with you, please don't take it elsewhere, IM ozone gas at 18 gamma.
Did they report any kind of complications at the injection site or pain to the patient on injection?
Zero complications. Yes, there will be some discomfort. It varies from patient to patient. And one of the reasons why it was done this way is he was treating patients in his parking lot rather than bring them into the office. So he would just run out. He gave them the nutraceuticals. He gave them an IV of ozone. He probably would he might have given some IV vitamin C as well in selected cases. And no complications, no problems. I have had IM ozone myself. I've given IM ozone gas, and it is not a nightmare. And I think it should work as good as the minor therapy.
Well, in my experience, injecting ozone gas has been very uncomfortable for patients. I mean, remember, you're injecting about 10 cc's of gas in the muscle, and the muscle fibers are getting torn apart, and you get these stretch receptors. And I saw one patient never wanted to have ozone therapy again. So that's my experience.
And I can't argue with that. I think it was done this way because of reduction of contamination and drawing blood. If you're in a hospital, you're already in a hospital, and you'll have better ways of doing it, including maybe minor autohemotherapy, taking the blood.
I did have a doctor taking it to a hospital in Wisconsin, and the board rejected it because the staff was concerned about drawing blood. And I'm like, aren't they in a hospital? Don't they already have a midline? So I thought that was kind of weak, but it does happen.
Okay.
I'm noticing that there are 28 folks on the call and everyone has different experience and perspectives on this, and it all sounds valuable. Jack, I wanted to suggest, what if we take a couple minutes and everyone put their thoughts right now into the chat, and then someone can synthesize that and pull it back together so that we can all have voices heard in the conversation right now. What do you think?
Yeah, but guys, you have to think that the Italian people and our Spanish team were using this method, with more traditional. So if you want to justify the previous experience treating patients with COVID in different countries with publication, you have at least our case and the Italian cases. So I think it's easier to get the approval you have used before in other countries, because there's no information about COVID and Ozone. So everything will be published is going to be help for everyone to want to start. So this is what happened. They request information, they request publications for COVID and Ozone. So if we did the same method, the Italian people, I think you have to follow us and do the same. This is my opinion.
And I think I'm in agreement with you, Alberto.
I think it's been established that it's going to be
it doesn't matter it doesn't matter if it's the best or not is the best, but this is what we use. So Italian people use, Spanish people use. We publish already, they're going to publish. So I think if you want to fight, you have to use the same, because it doesn't matter. You say, no, we do rectal. Yeah, you can do, but do you think you are going to get approval?
Right.
No.
You're absolutely right. And actually, Dr. Richter is relying a lot on your the Italian and the Spanish experience to draft our protocol. So what I suggest, Simone, what I was thinking is, you know, we've been doing this for an hour, and I don't want to, I know that different people have different schedules, and in Italy and Spain, you probably need to get back to your patients. Why don't we communicate via email? What I'll do is, Franz, when are we going to get the protocol so that I can share it with everybody?
Yeah, I mean, we have already, it's done. It just needs, you know, certain wording or editing. That's what we're working, but basically it's almost finished.
So what we'll do is I will share the protocol with everyone in this call. I will also share what our standard of care currently is at the hospital. We do use nutraceuticals, not IV vitamin C, but oral, and we use quercetin, and we use all kinds of stuff. But the idea is that this is a randomized trial. We're doing currently a randomized trial 1-to-1 with early use of convalescent plasma. So we're going to have patients that get the ozone and convalescent plasma, and we're going to have patients that get the ozone and no convalescent plasma. So because we're going to be randomizing both. So I think it will be very valuable. We have tocilizumab trial. We're using remdesivir. So we have people with remdesivir, without remdesivir, without tocilizumab. So I think it'll give us a good idea of what ozone does, you know, in addition to or in spite of some of these therapies. So I think it's actually a good thing. Any final closing comments? I don't want to impose on anybody's time, but maybe we'll do one of these again in the future. Go ahead, Doug.
I want to mention something important from my point of view. Professor Papadakos is not in the meeting. I don't know if he can or not, but he's helping a lot. He's from University of Rochester. He's one of the top critical care doctors in the U.S. Three times I don't know in English, but the gold from the Congress. So he's just published online a very interesting report about ozone therapy in anesthesiology news. It's online. It's going to be published in paper next month, and it's around 2 million of anesthesiologists getting this information. So I think it's going to be noisy around ozone therapy. So I think we need to push with this also noise in the environment to try to push to the FDA. So everyone can access to the article in online now in anesthesiology news. So just put Peter Papadakos and ozone therapy, and you will get it. And it's doing a very good paper about the benefit of ozone therapy with some of our cases. So I think it's going to help.
I think ozone has reached its kindling point in medicine. I think the time has come, next year or so.
If I could ask people to forward your reports to info@texasrighttoKnow.com, I will add them to the collection of reports of anyone I've gotten are right there. So a lot of people are still contacting me based upon that April 2nd press release. And actually, I've been quiet, Alex, like you recommended since then. But as soon as Larkin gets approval, Jack, who is your PR person
I'll connect you. I'll connect you. I mean, our goal is by the end of this week, we're going to submit it after we get everybody's input. And then we're hoping in the next couple of weeks, we'll have some answer back from the FDA. So we're going to move aggressively. And anyway, there's some question about funding. The hospital is self-funding this for now. So there's no issue with that. Actually, Dr. Richter is helping us with some of the equipment, and Dr. Domb is also helping us with some of the equipment. So I don't think for now we're worried about funding. I think we're ready to go. I want to...
Jack, I know another thing was getting this consistency in what markers are going to be used for identifying it. Try to keep those tests as simple as possible so that those who may not be funded have a lower testing overhead.
So yeah, so we will be sharing everything with the group so that you can add any markers that you feel we're not including. So we'll take care of that. But anyway, I wanted to, unless there's any final comment from anybody, I don't want to impose on your time. I think this was a great meeting.
Just one here, Jack. I don't think we've come to a very good conclusion about what to do with patients who don't have adequate veins for MAH, and it's going to be a significant number of those people. The question is, do you put in a port, or do you go then to some other alternative therapies like intramuscular, like rectal insufflation, et cetera, or you just bounce them out of the study?
What we are doing,
go ahead, sorry.
What we are doing in our center is in a ICU, we use central specifically for ozone therapy. So the patient is with jugular, we put femoral, and we use the central line for ozone therapy in intensive care. And on the ward, we're trying to do, like a catheter short, longer than the traditional catheter to keep there for the therapy, usually 5 days. And it says no, we try to find the vein with the ultrasound. So it's not been a big issue for us, but I understand other doctor can be in trouble to get vein access. But in our case, we use ultrasound to get the vein, so no problem for us.
So just a couple quick things. Number one, something that's going to be really helpful is if anyone in this group feels they have a really good understanding of what the FDA is going to look positively versus negatively on in an IND, that would be great, because basically me and Simone are just making our best guesses on what looks good versus what looks bad to have in it. And if anyone has more direct experience with that and can help with the editing process, that would be great. My guess is Dr. Thorpe would be the person who's most familiar, but I really don't know. The second one is that if anyone has ideas for additional references we can use, it would be helpful for this, where they can just write what the reference says and a brief citation. Those will be good to put in. It's very clear from listening to all of you that even though I have spent an enormous amount of time looking through all the literature, you're familiar with a lot of things we're not aware of that have not been put in. And more than anything else, the goal we're coming from is we just want to do everything we can to get this started and running as soon as possible. Then I also had a very minor question for Dr. Valdenassi, which is that with the CO results in the first, second, and third report, are they pooling from the same patients, or does each report have different patients? Because I assumed there were separate groups in each one, but when I heard that you've only done it on 100 patients, that would imply that all the people in the second report are also including the first, and all the people in the third report are including the first and second. And I just want to make sure that's accurate for what we write in the IND.
Can I suggest that we do that via email? Would that be okay?
Yeah.
Alex? Okay, so maybe just communicate with them via email. I think Dr. Marcus had one question, real quick, Marcus, so that we can conclude. Go ahead.
So very quick, there's two ways here for the FDA. One is the scientific merit. Those are the publications and the design. And there's the safety concern. They also accept unpublished preliminary data from the institution submitting. So if the worst thing that could happen in terms of toxicity, we know what those signs are, we can get 2, maybe 3 healthy volunteers. We can do a session, wait 24 hours, report if there's kind of adverse events. You can increase the dose, and that will be sufficient evidence to submit.
Dr. Richter and the medical resident. Where you have to do
tempo ancora.
He would
Pronto?
like to say
Posso
something.
parlare?
May he say something?
Io vorrei dire 2 cose veloci perché poi devo andare.
He has 2 quick things to
Allora,
say.
sono
then he must
d'accordo
leave.
con i protocolli standard, perché se non ci si presenta con un protocollo standard, l'FDA già sarà difficilissimo.
He is
Però,
absolutely, he agrees with you about the standard protocols. If you don't go to the FDA with a standard protocol, you won't have a chance to have it approved. It will already be difficult with the standard protocol, but if you don't have it.
poi avete chiesto che una nazione abbia dato il proprio ok, il nostro Ministero della Salute ha dato ok al nostro protocollo e noi ve lo possiamo mettere a disposizione.
You asked if any nation officially already had given its okay for a protocol. Our nation has. Our
No.
nation has given the okay for our protocol.
Non solo,
And not only,
ma la Commissione Sanità del Governo
but the Governmental Health Commission
ha invitato il professor Valdenassi e anche me a relazionare sull'andamento dei 100 casi che abbiamo
invited
fatto.
Professor Valdenassi and himself to make a personal report in front of the committee about the 100 cases that have been treated.
I pazienti arrivano da tutti i 15 punti, però vorrei dire una cosa, per fare un protocollo, prima ognuno dica che risultati ha avuto. Chi ha avuto il risultato migliore, quello è il protocollo migliore. Mi sembra molto semplice, perché parlarne in teoria non è che serva a molto. Noi sono 40 anni che facciamo ossigeno ozono, 1982, abbiamo fatto migliaia di casi. Su molte cose, devo essere sincero, non siamo proprio così concordi, ma assolutamente siamo concordi di portare l'ossigeno ozono negli Stati Uniti, sperando che l'FDA vi dia assolutamente ascolto e noi siamo ben presenti. Però via email scambiamoci i dati, perché parlare in teoria non serve. Allora, vediamo, io ho usato un protocollo, ho avuto 10 guariti, io ho usato un protocollo, ho avuto 20 morti, io ho usato un protocollo e ho avuto, e anche con degli esami obiettivi. Allora da lì sceglieremo tutti concordi assolutamente un protocollo. Io su quello sono assolutamente d'accordo e mi sembra la via giusta da condividere.
All right, just to make you understand briefly, because it was a long speech, our results came from 15 different hospitals. We were invited to make a report to the committee of the governmental deputies of our government. And both of us have reported what we have obtained, and our protocol has been accepted. In my opinion, we should all share our data, and before you present any protocol to the FDA, make a comparison of the best results obtained through the various protocols that all of you, including us, have. The best results, according to what are the best results, that is where the protocol has to be elaborated. We make the protocol, according to the best results. Let's work on facts, not on theories. That's what we have to do. And I fully agree with some of the things that you have shared with me and some others not, but I think that this is fundamental. Let's work on facts.
Agreed.
Noi abbiamo una pagina sul SIOT dove mettiamo tutto quello che facciamo e che abbiamo ottenuto con ossigeno ozono.
If you go on website, we have been on the market for 40 years now, so we have some experience with ozone, and there is a website where you can go and see all the results that we have obtained so far with ozone. Oxygen and ozone.it.
E poi l'ultima domanda.
Oxygenozono.it, that's our name.
L'ultima domanda è,
And the last question.
Stiamo pensando a dei pazienti positivi e ricoverati o dei pazienti sospetti positivi ma non ricoverati?
Are we talking about, generally here, are we talking about patients who are positive but at home? Or are we talking about patients who are positive and hospitalized?
Perché il nostro protocollo è per i ricoverati.
Our protocol is for those at hospital.
Same thing, hospital only.
Solo ospedalizzati.
Bene.
Okay.
Valde?
Yes, I think that it's useful compare clinical data of all the clinical protocols. So, and then in another time we may speak about this.
Before we leave, I know that Paulo, you and Alberto, there's been some comments about either using glass for the MAH, or I know that Dr. Franzini and the SIOT have special UV resistant plastic bags. What are you using for the MAH?
Resistenza speciale anti-UV, non
Alberto and Paulo.
Dice che non abbiamo il vetro, non usiamo il vetro.
Noi non usiamo il vetro, usiamo dei sacchetti che ha autorizzato unici il Ministero della Salute perché non perdono ftalati. Quindi è una plastica che non perde ftalati.
We are not using glass, we are using a special material that has been approved by our Minister of Health because it's a plastic that does not lose plastic residuals.
Yeah, we're using glass.
We are using that, no glass.
Non usiamo il vetro perché le rugosità interne del vetro danno un po' di emolisi. Se poi il vetro è tutto vuoto, peggio ancora.
We have seen that by using, if we use glass, there is, the glass is not totally smooth inside. And I think, I don't know what you say in English, we say rugosity, I think. The wrinkles inside the glass may cause hemolysis.
Roberto, were y'all using a special plastic or using regular IV bags? Because I know a lot of doctors.
We use both. The important thing, I think, is the certification. In our case, we're using glass from Germany. It's a material approval for Germany and the Community European. The advantage is the system has a negative pressure, so once you get the vein, you don't need to put the bottle on the.
La pressione negativa forma emolisi, che non sia certificato, non importa. Noi in 40 anni abbiamo selezionato il meglio di quello che sono i materiali.
Negative pressure causes
il sottovuoto, anche perché quando tu vai a reinietarlo, quando lo metti nella boccia di vetro, ti tocca sempre aiutarlo per rientrare con altro gas. E quindi cambiano tutte le proporzioni.
He says if you are reintroducing what you have extracted from the body
molto bene le cose.
again, so you are extracting the blood and then reintroducing it. If you're using glass, the negative pressure doesn't let the reintroduction go smoothly, you have to help the reintroduction by adding some gas. And then all the balances that you have obtained before are spoiled.
Got it.
No,
We'll take all that into consideration for sure. And I mean, Dr. Richter is listening, and we were looking at those options right now. So let me just conclude. I don't want to abuse of your time. I want to thank everyone for joining us from all over the world, and just tell you that we're all at Larkin very excited to partner with you, and hopefully this will be something that will at least in the United States show that this therapy is effective. So I want to thank you all, and we'll communicate via email. Thank you.
Thank you.
Thank you.
Have a great day.
Everyone.
Thank you.
Bye.
Grazie a tutti.
Thank you, everybody.
Thank you
Is there
very
going to be
much.
another meeting?
Ci
Yes,
vediamo.
we will. We'll schedule it via email.
Ci vediamo e grazie.
Thank you.
Ciao Valde.
Thank you.
Ciao.